So it's a 38-year-old woman. She has a sister with bad RA, just like Artie said. Well, what do you mean bad RA? Well, she's on methotrexate and a biologic. Okay, sounds like she's got bad RA. She was and her sister is debilitated. And the patient here, asked her PCP to test her for RA. She really has no arthritis or arthralgias. If you talk to her, she goes, "Oh, I do needlepoint. My hands sometimes bother me," but she's generally healthy. She smokes about a half a pack. She's quit in the past and is trying to quit again. She has 2 healthy children. No, and her BMI is not 1 here. Her BMI is 31. All right. In Cleveland, that's normal, but that's bad. I'm from here. I can say that. If you say that, I'll be really mad at you. She drinks a glass of wine with dinner 3 or 4 days a week. Does not use drugs. She has some moderate anxiety and depression related to, in her mind, when you talk to her, she's working, financial issues. She's certainly not suicidal and has never been medicated for any of this. But I don't know how you assess this, but we're going to find out. Otherwise, her rheumatic review systems is fairly unremarkable. She has a cold stone normal physical exam, but she brings these laboratory tests here that show this rheumatoid factor of 33 and an ACPA of 68. So you're now doing office ultrasound, and these fingers that bother her, you run her through this thing, and they are normal. So this is audience response. So given, you've heard all the facts today as they are, so given this scenario, what do you think the odds of this woman developing rheumatoid arthritis are in the next 3 to 5 years? It really is, what it is. Okay, this is like a Gaussian distribution here of things. So, very few people think it's very, very low, and there's some degree of uncertainty, and that's the data are the data. So this is what this crowd thinks. So in your evaluation of this patient, now this is to the audience. And you guys can respond to this mentally because I'm going to come back to you. Which of the following domains here? So now here she is. She's totally healthy, normal ultrasound. We've already heard you're going to have her come back every 6 months. That's what the audience said earlier today, and see what happens and that. But now I want to know what you're thinking. Which domains do you think are actually impactful for her ultimate risk of developing rheumatoid arthritis? Let's start by her smoking. All right, this is a free kick at the ball here. Rate right now how you rank this. She smokes half a pack a day. So not very high, moderate risk, but moderate to high, and maybe we can drill into that as we come back toward this. So now this whole deal here, you've heard about IgA and plasma cells and all this stuff. Impact of oral hygiene on the ultimate risk of developing RA. What do you say? So, not kind of a similar left-shifting thing. All right, so now let's talk about something else. She's sedentary, all right? She, has had a job in a call center. She really does no willful exercise that you can ascribe to. Does that mean anything to you moving forward in this whole deal? Please respond. Same parameter. No big deal for most people here. So it's kind of a neutral thing here. So I guess it's okay to be sedentary in this auditorium. All right. So her BMI is 31. Just to remind us what people look like at these things here. Does this mean anything to her projected likelihood of rheumatoid arthritis? Can you respond to that, please? Okay, so it looks almost like oral hygiene almost, all right? So you're very hip, and you do promise data for people coming into your clinic, and she ranks a score of 76 on this, kind of on the high side of the promise anxiety scale. This is where she comes in. Does this have anything to do with anything in terms of her risk of developing this immune-mediated inflammatory disease in your mind? I mean, these are, we're going from, this is the patient, and so we're getting the view of what's going on here. Well, that's interesting. So people are on the psychosocial scale. All right, so she describes her diet as a sad diet, and just to remind you, it looks something like this. Looks pretty good, doesn't it? Actually, so this diet that she has on, does this have anything to do with moving forward? Give us your best shot of your concerns. This is actually a great cross-section of people to ask this to. Getting an instant brief report here. All right, and this looks very similar to oral hygiene to me. Okay, so in terms of lifestyle recommendations, aside from smoking cessation and treatment of periodontitis, now I want to ask you, I want your confidence that diet, exercise, and stress can be contributing to disease pathogenesis moving forward. So this is now, rubber hits the road. Is it just give up on it, have no idea, or maybe if you're confident you should do something or not? Well, I would say that over half the people feel have a tendency here to think that this is actually doing something. So that's kind of interesting. So here's one of the many different iterations of disease progression that's been shown that, and we've talked about today. So in the extreme left, here's someone who's genetically predisposed with a shared epitope and has a varying, who showed the slide today said the expososome. Somebody had that on one of their slides. It's a great word. I had to Google it while you were talking, but it's the sum total of all your exposures in your environment. So, but nothing is happening. But somewhere along the line, as Mike pointed out, there's this pervasive sensitization to autoantibodies, and then a breach of tolerance. And in this patient, essentially sounds like totally asymptomatic. And then down the line, we're talking about the prospects of something actually happening here, developing some signs or symptoms compatible with some form of inflammatory arthritis, or ultimately possibly classically rheumatoid. And everybody knows that this is not always linear, and some people just show up, but this is, so we would have to put our patient here down kind of in this two spot here. There's detectable autoimmunity without clinically apparent tissue injury, as good as we can do. So here's a bit of data. This is some Paul Peter Tack from a very small cohort, and I actually was poking Mike about this by email a couple weeks ago. So in 55 asymptomatic patients with ACPA or rheumatoid factor followed for 27 months. In this group, 27% developed RA. If you were a smoker and you're obese, it was 60%. If you were a non-smoker and non-obese, it was 2%. So that's kind of an interesting biobehavioral aspect. This is obviously, I don't know how, you can interpret this any way you want, but these people are not equivalent. They have different expososomes. They probably have different metabolomes for sure. And if you looked at them in systems biology, like Dr. McInnes, I'm sure that there would be some differences. So having said that, so here's this audience. Here's what we're thinking out here. And then these are the guys that are the experts up here. So, all right, so Ed.
There's only one Ed.
Okay.
The only Canadian in the audience.
Okay, I'm asking you and Iain this because if you get this wrong, you're going out the country. So we've got the...
Wait a second, can I go now?
So yeah, everybody knows this oral hygiene is an important thing. You got this P. gingivalis, you got this aggregatibacter thing going on. You've got all this data about IgA plasmablasts. In this woman here, what do you do about oral hygiene? Do you say, like, I look in your mouth, like, it looks okay, it looks bad? Do you say, I want you to go see an oral hygienist? I mean, what do you actually do?
Up till now, nothing. But what I might do after this chat is I might send her to an oral hygienist or to a physician or a dentist and say, look, let's just check out your your hygiene, and let's see if it's reasonable for age, stage, etc. I see nothing wrong with that.
So let me ask any of you guys here. So does anyone have a standard of care that addresses this more than?
See your dentist.
Well, I have a really strong standard of care from my patients with Sjogren's syndrome about how often they see their dentist, but I don't have that from my RA patients. I know this data very well, and I'm thinking like Ed that maybe I should. But the question is it going to be like smoking, where it takes 20 years of not smoking to make a difference in how you're going to do? We don't know that. I mean, right now when we see these patients and they're preclinical and they have risk, how do you change the outcome, and how do you change the story? And lifestyle is an easy way to intervene, but I think doctors are notoriously bad at actually giving good instructions on lifestyle. Eat healthy, exercise more, lose some weight, but it's not truly prescriptive.
Well, let me be devil's advocate here and say that, no, I think that some data from today's discussion is that we have to await these studies. We have to know a numerator on top of the denominator. We don't know that. But in the meantime, there's people here in the clinic. So I think that I share that intellectual kind of black box person with you, but I'm now going for the practice. Anybody else?
I just want to say, if I have to make a mistake in terms of therapeutics, I always err on the side of the patient. That's how I treat people.
Okay.
So if
Is that over-treatment or under-treatment?
Going to the dentist is not over-treatment.
Good.
So therefore, if I have to make a mistake, why wouldn't you say, I don't know the answer, maybe 10 years from now, but as we say in Jewish, it wouldn't heute. It wouldn't heute.
I think we all get that. Artie.
I think one of the things with patients is they're drowning in meaningless use sort of stuff. You go to the doctor, they yell at you about everything. Wear your seatbelt, brush your teeth, lose weight, don't keep the gun loaded, all these things. So I tell them...
Maybe that's kind of important.
Especially... Well, if you're depressed, yeah. Especially in the psoriasis patients, I look, you're gonna hear all this stuff, but wait, I really mean it. Really, really, the weight. Let's just talk about the weight. Go drink what you want. Go load the gun. I don't care. You gotta lose weight because it's hurting the disease. And I think when you pay, it's not just a checklist of things like they do in the intake that is like, yeah. I think it's hard. The oral hygiene, though, the confounders here, obviously the smoking, but they're the diet, too. I think for our gout patients, we've been convincing them that high fructose corn syrup is bad has been easier than I thought it was going to be. It's something that nobody has really sort of paid much attention to, but it's sure bad for your teeth.
Okay, so let me Mike, you're the kind of the arbiter on this. So I want to just hold you back for a second here. So I want to ask anybody here. So, I mean, there's a lot of, you guys see more patients than these guys. So anybody have a best practice for this? Or do you just look in their mouth like I do and kind of size this up, or thoughts?
Yeah, a couple of comments. We, of course, are looking at this right now, and we're pretty early, but we are looking at, we're having formal exams, looking for periodontitis and doing strips where you pull in the antibodies out and you look at cytokines and you look at the microbiome. So I'd say it's an evolving area. I think it is relevant to point out that the associations have actually been with P. gingivalis and the Agrobacter, but those have actually been with individuals who had active RA. The only really good looks at new onset, Nora, Jose Scher, did not see P. gingivalis or this other. So I think there's this stage specific. But I think it is relevant, it makes sense, but I think you're really looking for periodontitis, not looking for, quote, poor oral hygiene. And we've been impressed that we're not very good at telling what's periodontitis from just kind of looking at something else.
So anyway, a good question mark and a good place to go. Jack, do you have a final?
I'm concerned it's a little bit like vaccination. We all know our patients should get vaccinated. We probably all are suggesting it's doing this. There's tremendous give up, and as you'll show that there's a tremendous deficit in the vaccines that need to be done, because how much time do you want to spend? I spent 1 year, it wasn't this year, it was the year before, where I really went after everyone. And and when they said no, I say, how come? And when they said no again, I said, what if I give you $6? And then I kept upping the amount to find out how much it was going to take for them to get a vaccine. But they're getting the point that it's vaccine. I could convert a number, but it's a time suck. I mean, it really takes a tremendous effort, and most people are too busy to do the work that should be done.
Jonathan?
So there's an undercurrent to this discussion, which is really the lack of time that we have with patients with rheumatoid arthritis.
It's going to be pervasive for the next 8 things I'm going to ask
right.
you. So let's get it out right now.
So it points out the need for someone like Betsy or a nurse practitioner or a PA to really sit down and spend time talking about these lifestyle issues.
And we're going to come to that in a second. All right, so this smoking deal. Who on the panel here has a formal algorithm for smokers? Jack?
Smell them first.
Well, I mean, that's sensitive, but not specific, because their husband could be smoking.
You get to be artful in how you smell them, and then look for tobacco stain. But I mean, it's really apparent, I mean, who the smokers are. I mean, there's a number, obviously, who still are smoking a few cigarettes a day and whatever, but that's really when I really put on my smoking talk, because those are the real abusers.
Who here has a formal referral pattern for smoking cessation? Ian?
We do.
What do you do?
And
Who do you refer them to?
to those people?
The bartender.
We have an online cessation course, and we have. I mean, obviously, it's the UK, it's the National Health Service, so it doesn't work by definition this side of the Atlantic. Miraculously, in fact, we do have excellent smoking cessation programs available through primary care physicians. We also have, through Helen Harris in Fife, a fabulous online imagery course. I don't know, you've maybe seen these pictures. She's superimposed nicotine stains and smoke over the MCP and PIP joints. That photo imagery is a very powerful way of linking the risk of rheumatoid and the risk of non-response, which is really what I've heard being discussed. I'm going to come back to that in a moment, because I think we're deliberately missing the ball right now. So in fact, that's our smoking cessation rates are satisfactory, if not spectacular.
The data is pretty clear that patients doing it on their own, not very successful. They need to be in a system, a program, and then often with medication support for the best outcomes.
I think it's very local, regional. We've addressed this before, and depending upon like where you are, the state of Ohio has smoking cessation tracks. We have a wellness institute where we can refer these people. Anybody here routinely prescribe Chantix or Wellbutrin or any things like this? I think that we'll move from point 2 saying that, in the best of all possible worlds, it's not enough to say this is really bad, and some type of algorithmic referral would be ideal. So I'm not here lecturing, but I'm just pointing out areas of need. All right, so this diet thing, okay? So on the standard American diet, it's not good. Where do you go in terms of best practices for this? This is do you use formal nutrition? Do you have handouts? Do you have materials? Do you have anybody in your practice that works with this, or is this is not rheumatology and go someplace?
Well, patients ask the question all the time. And I think we all pretty much have the same answer, that there isn't a standard win every time approach to your arthritis, meaning like, cut out Snickers bars and you'll do fine. It's not the answer. But I do think that, what Artie said as the advice for psoriasis does work, because obesity is a big problem when it comes to drug responses and risk for disease. So that being the coaching, well, by whatever means, is probably the right way to go, without necessarily getting specific as far as gluten-free, a paleo diet, any avoiding meats, whatever. Those have not proven to be beneficial in any hands.
Yeah.
I'm a bit confused by the moderator this afternoon. I'm easily confused, you know that. So I'm still thinking about this woman in her late 30s who's actually not got rheumatoid arthritis. Mm-hmm. But I'm hearing a lot of conversation about how we treat their patients. And so we've made this lady who doesn't have criteria-proven disease, we've made her into a patient. So I actually have a completely different approach here. I wouldn't be majoring on disease prevention for this lady. She's already terrified. Her sister's got bad RA. She came to us thinking, I'm in trouble. She's already pretty motivated to do something about this. So I have several objectives in the conversation. Objective number 1, I need to link elements of her lifestyle behaviors not only to risk of RA, but to the risk of not being well. So one of the reasons that doctors and patients struggle, so comorbidity is a big interest of ours in Glasgow. We work very hard on multimorbidity. We've been looking at mechanisms and management of multimorbidities across a range of diseases for the last many years, and sadly that's because we have so many of these diseases in young people. And I think the challenge here is actually to set out I think I've heard it from several colleagues, the why not question. We will work towards wellness with you, and one of the benefits of that will be to minimize the chance of you ending up like your sister. So the reason you want to stop smoking is, I think our friends from Indiana put it right. The reason you want to stop smoking is that you're going to have a heart attack, a stroke, or cancer sometime soon. And by the way, because I can't give you a number right now, because I can't, in addition, by stopping smoking, you will minimize the chance of looking like your sister. The reason we need to alter your diet, because this is not yet a disease state, and I'd have a very different approach if I was treating somebody with established disease. Someone with established rheumatoid, when they come in talking about dietary supplements and reduction diets, they've been on the internet. They've been reading whatever the Cleveland Clinic said last week, which was avoid this, add green tea, gluten-free because I don't have celiac. They get back pain bringing in all the bits of paper they printed of this week's advice.
That's also called Notalgia.
Yeah, absolutely. Notalgia is very good. So I think, Len, I'm getting a little bit confused here, because this consult's for a worried, rightly so, young woman who's broken tolerance. And when we're talking about avoidance behaviors, and I'd love to hear Mike's view on this, because we've already got someone whose immune system is misbehaving. So if the original sin that the microbiome and the genome committed, those stochastic events, were actually, that sin is being committed. So what we're actually trying to do is to prevent immunologic progression and tissue localization. And with the best will in the world, I've got no idea what's going on there. So you're right now in 2017, as physicians, we have lots of evidence for the right reasons, that oral hygiene, dietary management, weight reduction, smoking cessation is the right thing for this woman to do. And in addition, she is likely to be reducing her overall risk. If you take that strategic approach with people, you have the evidence of medicine behind you, and you have common sense with the patient in the room. If you start to tie this to rheumatoid risk reduction, and she comes in with swollen joints 6 months later, you're lost. She's going to somebody else.
So let me interject and come back to you. So first of all, this is a straw man discussion. Second of all, what we're actually talking about here is wellness. And what I'm trying to probe from a group of masters is that what do we as a community, what is our approach to wellness? I mean, you can, we established at the beginning, we don't know what the hell the outcome of this is going to be. But, and even if she had a negative rheumatoid factor and a negative ACPA, I would be acting exactly the same, moving this toward wellness. And I don't know if you looked in your little bag there, but I put in my monograph on wellness, which I give to every single one of my patients, which deals with what not to do, what healthy eating is, what the role of exercise is. And I frame this all from the perspective of what I call immunologic health. Health is health, but it's a good paradigm for people with IMIDs, and they can see this. So I'm just trying to poke you guys a little bit, and people here who have best practices to see how proactively we are, and maybe make us think, since the audience here seems to be fairly impressed that these are actually important things, something that we might want to be engaged in a little bit more. Comment?
I hate to interrupt, but Iain's right on point. I think we need a little deeper dig into what the biochemistry of wellness is. And I'd raise a point of Paul Peter Tack's paper and Frieda Koopman about a year ago, demonstrating that autonomic testing with heart rate variability was a predictive factor for developing new RA. And this is a young woman who has anxiety. She may have hypermobility. If you follow Rodney Graham's work on autonomic dysregulation being an extra-articular manifestation of EDS3, she's overweight. Sleep apnea is very common among patients with RA. Look at Shamizu's work in 2003. Her diet's no good. Smoking is an activator of sympathetic tone. So you've got one more autonomic thing after another here. What we don't have is you don't have a test to actually quantify it in the office, but someday you will. So just throw that out there. It's all about wellness, but it's about the biochemistry, what underlies wellness.
Many domains to discuss. And we're just going to take a couple more before here. I think that certainly, go back to the audience here. Actually, people were more impressed with her sedentary lifestyle than some of her other things. How do you get your patients to engage in exercise? Do you have a best practice? There's no argument with your point, and this is not, I'm trying to craft this into an overall approach. None of this is going to get done at one visit. And in fact, our approach to wellness is that, just to talk about our practice, that we have flat screens in every one of our examining rooms in the Fasenmyer Center, and there is a constant kind of PowerPoint going on in the back that talks about exercise and health, diet and health. We have plant-based recipes. We talk about, ask your doctor about immunizations. We talk about brief intermittent exercise. We talk about mind-body exercise and meditation, and we provide resources. And we never cover all of this at any given visit, but rheumatology is a marathon. And you're going to see these people. I've been seeing people for longer than my kids are old. And, you can have that little conversation about, how you doing? You got rid of those, sugary drinks yet? Or, how we doing on the smoking? And let's just peek at your weight. Yeah, none of this is all going to get done at one visit. I'm just probing here for best practices. I actually, in the world of rheumatology, since I've been talking about this about the last year and a half, I'm impressed at how how into this topic that our community is. And I sense a large gap in both declarative knowledge and procedural knowledge on how to move this forward. So I'm kind of into this. Maddie?
So I've been talking about weight loss for many years with my patients, and I agree it's not something to discuss at the first visit. It's something to bring up kind of later, but I've found that what seems to be the most successful in as neutral and non-threatening of a fashion as possible is to actually pull up on the computer the patient's current weight and calculate their BMI, and usually the BMI is not there, but I find the weight and the height, and I go to Google and I do Google BMI calculator, and we plot what the BMI is and what the BMI, which inevitably often is higher than it should be. But then the next step is to say, well, really what you should be aiming for is a BMI of this, and that corresponds to this weight, and to give them an actual weight, goal weight that they should be aiming for. And for patients who are morbidly obese, it's just completely unrealistic. And so what I do for those patients is to suggest losing 10% of their body weight, which is 100 pounds. That's 30 pounds of weight loss over a certain period of time. And the fact of giving them an actual goal number, an actual weight, and to tell them there's always something. There's always, Valentine's Day, Christmas, New Year's, whatever. So I always tell them, at least I want to see you at the same weight. Maybe not have lost weight, but let's make sure you have maintained the same weight. And I also ask them if they have a scale, because a surprising number of patients do not have a scale.
Excellent points. And it's great to be able to have resources for referral for particularly people who have more morbid obesity. Let me just ask a couple more questions here about that. You brought up the weight loss. I'm going to do that. Wine drinking I'm not going to go into because we'll just switch, make sure it's good wine, and perhaps red wine is a leg up there. Mental spiritual health. Everybody seemed to actually click into the anxiety depression thing here. And how many people or have any best practices for this other than for people who have significant? How many people routinely assess mood in their patients with some metric? Pretty good, pretty good. And how many people refer for any type of mindfulness or meditation for select patients? We have, that's pretty great. Well, you're at the Mecca here. Jonathan, why you want to bring that up?
Sure. There's a mindfulness program that's based at UMass and has been disseminated around the world. John Kabat-Zinn started it, and they have a formal training program where they train patients and providers in various aspects of mindfulness, and it helps tremendously. There's some small studies that look at combination of mindfulness training with DMARD therapy and better response to DMARD therapy. So not only in preventing disease by controlling anxiety and depression, but also adding mindfulness training as an adjunct to current therapy.
I couldn't agree more. My criticism of the MBSR program there is that I always say it's an hour of meditation a day and 8 hours of orientation. I said if I had an hour a day to meditate, I wouldn't be stressed. But what we're working on in this space and others have is that it really does, that is the gold standard of stress reduction and achieving a mindful state. But the dose response, there was no notion of dose response. And our data shows that mindfulness meditation sessions of perhaps 15 minutes, as little as 3, preferably 4 times a week, can have profound effects on psychometric parameters. And so I heard a really interesting talk at that IAS meeting in New York. I don't know if you were there on Sunday. These 2 psychiatrists in Texas. These 2, they're in Austin, and they're doing a project with UT Southwest, apparently. And they have a combined program of mindfulness on CDs, some dietary checkoffs, some exercise log, and sleep restoration. And they've got extraordinarily good metrics of wellness parameters, looking at PROMIS data and things, bringing people up, and now they're applying it to inflammatory arthritis, and the psychiatrist actually says he has rheumatoid arthritis. So there are things in the palate that are available to all of us, and we're just starting to learn this. And in fact, at ACR this year, there's going to be a symposium that has mindfulness and burnout and empathy, and it's actually coming front and center into the body of the scientific meeting. So I wanted to bring this up.
I think one thing you can do is you can we should all be protocolizing as much of this as possible, meaning that I use a patient survey form at every visit first or follow-ups. It always asks about diet and always asks about exercise. What do you do? And it asks for detail on that, sleep and other things too. And then when it comes to a problem you've identified, whether it be obesity or smoking or alcohol or depression, they have to be a problem. That is still an active problem that has to be dealt with visit to visit by you, even though you're the rheumatologist.
I think that's laudable. I think that doing psychologic screening like PSQ9 or something, you'll find the people that are in the red zones. So, I mean, it's all part of this process. So, at any rate, let's take this just same patient. I only ask one more question. So now she has positive ultrasound in her digits. It's a different deal now, all right? So, let's all say that whatever the likelihood of her developing RA, she either has RA or is clearly going to get this. So now in this patient who now has early inflammatory arthritis, certainly doesn't meet any criteria and has normal plain films but has this much, just go around and tell me what will be your therapy for this person.
So given that this patient is seropositive with both rheumatoid factor and ACPA and has powered Doppler signal, I'll put this patient on methotrexate.
Artie?
Dose pack or dose pack equivalent, very close follow-up.
Steroids. Oh, my God. Okay.
Professor Keystone.
Oh, yes. Well, it's actually...
He's meditating.
No. No, it's called sleeping.
There's a difference.
There's a difference. Well, the problem with the power Doppler, to be honest, is it depends whether it's grade 1, 2, or 3. It's grade 1
so
means nothing.
There's tenderness and there's some kind of signal.
But significant.
There.
A touch or more. If it's more, I would certainly consider methotrexate. If it's a touch, I'd put her on Plaquenil.
Does this patient qualify for stop RA, or is it too much?
If this patient has inflammatory arthritis, then the patient would not get into stop RA because they...
So does that qualify for asymptomatic joint, but
yeah,
just...
Actually, the patient would actually get in as long as there are no swollen joints.
All right, so then
we don't do ultrasound.
You're putting it in the study.
Yeah. Yep.
Jack Meister?
Plaquenil. I think it is incredibly safe. I think it is actually just useful in people with pain. I think it lowers pain thresholds, and it may be beneficial while I wait for the results of the Stop RA study. Otherwise, if it wasn't a power Doppler, I might just treat symptomatically as Artie would.
Ian, do you have a study for this patient?
Yeah, she might just in the margins get into PIPRA that we're doing with Andy Cope, which is so there's 6 or 7 of us got together to look at a prevent progression. I'm actually interesting enough with Jack here. We did a very interesting audit stroke study in Scotland 5 years ago called the CARA analysis, and we looked at everyone across the country using our electronic linkage that I mentioned this morning, and we looked at the number of rheumatoid patients in remission after a year, and there was a very large group of patients that actually got to remission, and almost all of them were receiving hydroxychloroquine. and we were trying to work out why hydroxychloroquine was curing rheumatoid. I used that, by the way, very much in italics and parenthesis. And it turns out that docs are pretty good at choosing mild disease that's going to stay mild. Rheumatologists, believe it or not, are actually quite good at their job. Over the years, we've accrued gestalt and feel for these things. And my worry about going too aggressively at this woman is that we start to leave some of that gestalt behind and we become very institutionalized. I think Ed made a great point about per Doppler ultrasound. I'm beginning to get more and more worried about ultrasound in the way it's being advocated for use across the discipline. But let's assume this woman has synovitis and she's seropositive and she has this family history. I would give her methotrexate, in fact.
Yes, I think the complication was we didn't know when the synovitis began in that study. So and the statistical difference was only the 6 to 9 months period. So, or the 6-month period. So I think it is important, but we've been trying to assess people who are seropositive for joint pain, and there's a lot of joint pain. So and we actually have difficulty trying to understand what's arthralgia in our kind of a setting. So we've become much more biomarker based, but whether the work setting is going to be different in this period, I don't know. I suspect it will be.